Good afternoon, everyone. This month, we have been celebrating Women's History Month. Today, in conjunction with the College of Medicine, Department of Medicine Inclusion Council, Dr. Min Ju will present Gender Equity in Academic Medicine during COVID-19, Challenges and Solutions. This programming is sponsored by the Office of Diversity and Inclusion and also APA, HLPSA, ICHP, APHA-ASP, BPHSA, CPNP, and SNAPA. It has been approved for Domain 4 Flames, PDC 1 credit, and 1 KY point. The attendance sheet will be shared at the end of the programming. If you have any questions throughout the programming, please type them in the chat box. We will have a questions and answer session at the end of Dr. Ju's presentation. During the programming, we ask you to mute your microphones and turn off your cameras. And now we will hear from the College of Pharmacy's Dean Schumacher.
Well, hi, everybody. I just want to thank you all for participating, whether you're a student, faculty member in the College of Pharmacy or from the College of Medicine or elsewhere on campus. It's my great pleasure to introduce our speaker today, Dr. Min Ju. Dr. Ju is a professor of medicine in the College of Medicine's Division of Pulmonary Critical Care, Sleep and Allergy. She's also Chief of Pulmonary Critical Care and Sleep at Jesse Brown VA. Dr. Ju has been a colleague of mine for the past 20 years, and we've collaborated on a number of different research projects and papers, and I'm just thrilled to have her present today. She's a great speaker, a great colleague, and also very well qualified for a presentation today on Women's History Month. As mentioned, Dr. Ju is a member or co-chair actually of several committees within the College of Medicine on bias reduction and on inclusion. And I can't think of anyone better for the presentation today, given all of her work in diversity, equity, and inclusion. So without further ado, I'd like to welcome Dr. Ju.
Thank you, Dr. Schumacher, and I want to thank Clara and Hitomi for inviting me and also agreeing to make this a collaboration. And I really hope that we collaborate more on these topics moving forward. Today, I want to talk about gender equity in academic medicine. Actually, when I created this title, I thought I really should be talking about academics because I will be talking about the College of Pharmacy or the field of pharmacy as well. During COVID-19 and challenges and solutions. I have no conflict of interest to declare. So before I start, I wanted to ask a question of everyone who's here. Is diversity important in academia? And I think this is a really important question for us to just take 30 seconds to think about. If the answer is yes, or even maybe if you'd like to put a couple things in the chat, that would be great. So this question is extremely important because if the answer is no, and I hope it's not no, then the rest of my talk isn't going to make much of a difference. But I certainly believe it's important. And the reason that I think it's important is because it's important to the growth of our institution as well as the growth of our faculty. So Tel Whitney is a pioneer in promoting STEM careers for women. And one of her very famous quotes is that diversity drives innovation. When we limit who can contribute, we in turn limit what problems we can solve. And from a common sense point, this makes sense, right? Because our lived experiences differ, for example, based on our gender, our race, our socioeconomic status. So the problems we identify are potential solutions we propose, how we relate to patients and understand their barriers to care may also differ based on those characteristics. So in the clinic setting, for example, the shared lived experience may lead to better care because we can relate to the barriers to health that exist for many in our community and not simply just non-compliance and non-adherence, which are actually both power-driven terms, right, to our medical recommendations. that there's barriers that we need to understand, and if we have the same lived experience as our patient population, we may be better at doing that. In regards to research, for example, in a clinical trial, if you think about a behavioral intervention that you want to propose, which may look great on paper, but is it relatable to the target population? Will it be successful and implementable? Would somebody with a similar lived experience have a better solution to the problem? So if you believe that it's important, and if the answer is yes to this question, then we can talk about how to prioritize diversity, equity, and inclusion, and along with that, create an inclusive environment that allows people to feel a sense of belongingness. Now, I came at this from a common sense point of view, but there are several studies showing that diversity benefits academic medicine. And what you'll see in the little parentheses here is adapted from BRIM. I'll talk about what BRIM is, but I give full credit that a lot of these slides will be adapted from that workshop. So diversity benefits academic medicine. Diverse groups are more productive, they're creative, innovative, and engage in higher levels of critical analysis, and this has actually been shown. Diverse groups publish more articles in higher impact journals. When they looked at several journals and looked at the diversity of the authors that were more diverse were able to publish journals in higher impact, or publish manuscripts in higher impact journals. Diverse perspectives yield new approaches to teaching, research, and mentorship, which is what I mentioned earlier, but also that's been shown in various studies. And in medical school, for example, when white medical students at schools have a student body that's very diverse, they feel more prepared to care for non-white patients. And diversity decreases health disparities. And again, I think coming at this from a common sense point of view, but also there's literature to support that diversity does benefit academic medicine. So to start with, before I get into even the impact of COVID-19, we need to understand the status of women in medicine and pharmacy. And let's start by their status in academic rank. If we look at the numbers in 2019 and 2020, what you see there, and women at this point in 2019 make up 50.8% of the population, and we're graduating about 50% of the graduates in medical school are women. And if you look at PhDs in the biological fields, 55% are women. About 43% of women go into internal medicine residency programs, and we do a pretty good job of hiring them and bringing them into academics. Our internal medicine assistant professor proportion is around 46%. That's when we start seeing a little bit of a drop off. If you look at associate professors, that decreases to 39%. When you look at full professors, that decreases to 25%. And then when you look at IM chairs, that decreases to about 17% women. Now let's look at the field of pharmacy. Pharmacy actually does a fantastic job of graduating women. If you look at the 2000s and then 2010, the black bar is first professional degree, the gray bar is a master's, the white bar is a PhD. You see that about 65% of graduates with their first professional degree in pharmacy are women. And about 60% of the graduates are women when they obtain their master's, and it still maintains right around 50% when it comes to obtaining a PhD. Slight decline, but not too much in 2010, in the 2010s. But then when you start looking at the assistant professor, associate professor, and professor levels, you see a pattern that's very similar to medicine. So if you look at 2012-13, again, this is a bit outdated, you see that similar to medicine, we're very good at getting women into academic medicine. Assistant professors, 60%, very similar to the graduation rate. And then associate professors, again, around 50%. But then when you get to the professor range, again, you see this dramatic drop down to about 30%. Better than medicine, to be sure, but why this discrepancy and inequity? So that's really the question. Why do the proportion of women drop as we climb the academic ladder? And I think if we were to think about some of the more common assumptions that we're familiar with, really is, is it a pipeline issue? Are women just not graduating and staying within the field enough to climb up the ladder? And I would push against that, because I just said that half the women who graduate from medical school are women. 65% of graduates in pharmacy with their first professional degree are also women. And we hire them into academics and have great representation at the assistant professor level. And even though we recruit them initially, we see that drop off at the associate professor level and the professor level. Is there a lack of talent or interest or commitment? I can tell you that several surveys have been done looking at men, women, URN faculty, and they have similar leadership aspirations. And there's no difference in male versus female leadership effectiveness. And another assumption may be that, well, women choose families over careers. It doesn't really account for the discrepancies in career advancement per se. I think I would push back on this to say that if you ask women that are in academic careers, yes, they have family, they have household responsibilities, but their ambition to strive and succeed in academics is very similar if you look at the surveys, again, that have been done in the past. Is it overt discrimination? And I think most people would say that there's enough laws, policies, procedures in place where if there is explicit discrimination, those are things that are much more black and white, easily reportable, and definitely not a reason, less of a reason probably for the advancement of women. But again, with all of these disparities exist. So it's possible that there's a minimal component of each of these, but I think it's hard to say that these are the common reasons why women aren't advancing in their careers to leaders, to positions of leadership. Which really leads to a few slides I don't want to talk about implicit bias, because I really can't talk about women and advancement in medicine without talking about implicit bias. And I think that now it's pretty clear that most major organizations, including the NIH, AAMC for Medicine, National Academy of Science, has concluded that unintentional bias or implicit bias arising from cultural stereotypes operates in personal interactions or institutional cultures and evaluation processes to perpetuate inequities in science and medicine. One of the most exciting things that really happened to us in the Department of Medicine was BRIM. BRIM is Bias Reduction in Internal Medicine, which is a study actually that was originated from the University of Wisconsin. They created a workshop called Breaking the Bias Habit, which is a 3-hour workshop that had 3 modules talking about implicit bias as a habit, understanding the bias concepts, which I'll go over a couple, and then how to break the habit, which is probably the most important component of this workshop. And this workshop was actually pretty integral in kind of opening our eyes to what we were understanding as stereotypes and how we were expressing implicit bias without actually even knowing it. And then most importantly, teaching us how to really break that habit. Obviously, I can't go through a 3-hour workshop. I was one of 10 implementers who learned how to give the workshop. And at the time, every section received this workshop back in 2017. But I do want to go over a couple bias concepts that I think are really relevant to women. One is expectancy bias, which is a type of implicit bias. And expectancy bias basically means that we expect certain behaviors, traits, or abilities in individuals based on stereotypes about their social category, even if we don't believe in those stereotypes. And I think that's what's really important about this. And so we attribute different social categories, whether it's gender, whether it's race, whether it's a religious affiliation. There are certain stereotypes that we know are associated with them, even though we don't personally believe in them. And along with that is competency bias. So members of historically lower status groups, which tend to be women and minorities predominantly, are presumed to be less competent than members of groups that have typically held positions of authority. An example of that through the workshop, and I have to mention, is, for example, a medical student that just graduates from medical school and is on his first day in the ICU caring for patients, versus a nurse who's been there for 10 years caring for patients in the ICU. Sometimes we can have the assumption that that medical student who's now an MD may be more competent than a nurse that's been there for 10 years, because we have a competency bias towards MDs. The third bias concept, before I go into some examples, is role congruity and incongruity. And I want to stress that a lot of the times when we think about role congruity and congruity, expectation bias, competency bias related to stereotypes, we don't believe in those stereotypes always to be true. But because those stereotypes are so ingrained in us through media, through TV, movies, and so forth, they exist. And that's where our implicit biases tend to come from. And again, implicit and unconscious, because we may not even realize how it plays into the way that we interact with our colleagues and promote and help sponsor and help our colleagues succeed. So role congruity and congruity is basically the fit or lack of fit between group stereotypes and workplace roles. Again, even though we know we don't believe in those stereotypes. A good example of this is if I were to say to you, who would you envision if I said the word nurse? Immediately, most of you would probably envision a woman. If I said to you, who would you envision if I said physician? I hope it would be 50-50 men and women, but most likely a lot of you envisioned a man. Let's talk about a construction worker. So again, most of you probably envisioned a man. So that's this idea of role congruity and incongruity. So what are stereotypes that are associated with gender, even if we don't believe in them? And I want to start out with men. We know common stereotypes exist, again, even if we don't believe in them. So I want to give everyone just 30 seconds to think about men. What stereotypes do you think exist for men? Again, even if you don't personally believe in them. And if you'd like to put some in the chat or just think of some in your mind, that's fine.
Yeah, I know for sure a lot of people say that men are strong, muscular. Here, for example, Miriam Annis says that stereotype for men is they tend to be goal-oriented or ambitious.
Great.
We have other responses like they tend to be not such great communicators and tend to not express their emotions very well.
And I think somebody wrote haters. So thank you for those. Thank you for that. You know, and then some of the stereotypes again, and these are stereotypes that were identified through various studies when they asked college students. Again, similarly, when you look at pictures of media and movies and around you, what stereotypes do you associate with men? And the answers were strong, decisive, stubborn, competitive, ambitious, risk-taking, assertive, logical, authoritative, independent. And I can tell you collectively as a whole, these are considered to be more agentic or action-oriented stereotypes. Now let's do the same thing for women. Again, I'll give everyone about 20 to 30 seconds, whether you put it in the chat or not. Think about the stereotypes that we associate with women, again, even if we don't believe in them.
So for women, we were getting answers as in women tend to be stereotype as being compassionate, emotional, soft-spoken, very maternal.
Great, all great answers. And again, going back to the studies, a lot of these were mentioned in the chat: caring, nurturing, family-oriented, emotional, supportive, sympathetic, nice, helpful, dependent. And these collectively would be considered more communal terms, right? And again, stereotypes that we know are related, we don't always believe in them, but these are the things that lead to our own implicit biases. Now let's go to what are the characteristics of a leader. Again, I'm going to give people about 20 seconds or so, whether you think of an idea in your mind or if you'd like to put it in the chat.
So for leaders, we're getting responses as in people who are decisive, responsible, and authoritative.
Great.
We're also getting a good one from Roxanne Shoa, able to listen and communicate effectively.
So some of the more common stereotypes associated with somebody who's considered to be a leader: competitive, self-confident, aggressive, ambitious, powerful, and decisive. Now I'm going to throw at you, if you were to look at all the stereotypes that we just reviewed for men, associated with men, associated with women, and what we just said were associated with a leader, which of these do you think are more congruent? I think most people would agree that stereotypes that are associated with men, again, even if we don't believe in them, are more congruent with the stereotypes that we see for leaders. And I also want to make clear that, these stereotypes, again, even if we don't believe in them, exist. And when we don't act within the stereotypes that are sort of assigned or associated with our genders, there's actually social penalties. So it's not only that there are certain stereotypes that people are aware of that plays into their implicit bias. When people don't respond or act in that specific way, there's penalties. So for example, if you have a man who carries more of those communal stereotypes, think about like a stay-at-home dad, right? I think most of us now would think a stay-at-home dad, it's a career, they're taking care of children, but some of the social penalties are that they're weak, they're soft, they're lazy. I personally don't believe that, but I'm talking about generalities. And then if you have a woman who carries on more of those agentic stereotypes, then what are some of the labels, right? Women are bossy. That's probably nicer of one of a couple words. They're loud, they're angry, they're disagreeable. So again, there's social penalties associated with not aligning with stereotypes that people are familiar with, even though they don't believe in them. And people will say, well, that was maybe not so recent, right? That's what we used to think, and that's not really how we feel now. And I hope that's the case as far as not believing in those stereotypes. But this is an article that came out in 2014, Afraid of Being Witchy with the B, a qualitative study of how gender influences residents' experiences leading cardiopulmonary resuscitation. So this was a qualitative study where they asked residents through interviews how they felt running a code. And a lot of what was heard was that there's levels of anxiety, not feeling like it's their place. They feel like they were bossy. They feel like they were witchy with the B. And what was really interesting about this, I was asked to be a part of this as part of a journal club because this really resonated with a lot of our women residents. One component of this that I think a lot of us disagree with now was the strategies that were recommended by a lot of the women, because the women are adapting and they're resilient. They came up with strategies such as taking your powerful stance at the tail of the bed, or standing on a step stool. Like myself, I'm 5'1", so I related to that to some degree to show that you are the one leading a code. Putting your hair back in the ponytail, always having your white coat on, et cetera, et cetera. And I think one of the things that we realize about this is that we actually apply those implicit biases to ourselves, but also understanding that those implicit biases are coming from other individuals around us. So I'm not sure it's always so healthy to think about changing just ourselves. I think we need to change that environment so that we make people aware of the implicit biases that they apply to women and work in that front. And so we will be having a session, if people are interested, called It's Not You, It's Them, Unmasking the Real Imposter on April 22nd, where we're gonna have a really robust discussion about what imposter syndrome means and whether it should be women who's labeled with that or everybody else around us. And what we can really do to sort of overcome our own implicit biases. So now on to the COVID pandemic. So one thing we realized was that the COVID pandemic really stressed systems and it revealed structural problems. And what do I mean by that? I mean, during the pandemic, I was involved in creating the physician workforce at the university hospital. And then I was called over to the VA to do something very similar and have the VA plan for the pandemic as well. And one thing that you realized was that when you were skating by or when you had a structure that wasn't very well organized or in place, then all of the deficiencies would start to rise when you stress the system. And I think that's very similar to what happened with gender equity during COVID. So if we think about prior to COVID-19, I mean, and there's multiple studies showing this, so I'm hoping that people will take this as not just my opinion, but fact that household labor responsibilities of women were more than men even before COVID. And with the onset of COVID, it significantly increased. We lost our people who would come in and help us clean our houses, food delivery, and I know these are first world problems, but this is just additional work that women had to take on during the pandemic. Childcare responsibilities have always been disproportionately more on women versus men. And this also increased because there was almost an overnight a system that required a transition to remote teaching and learning for various age groups, 5 and up, and changes in the grade systems and making sure that our children were continuing to succeed. We lost our nannies, we lost our childcare. They were sometimes scared to work with physicians, or they would have to quarantine for 14 days, or we would have to quarantine for 14 days, or our children would have a sniffle and we didn't know whether that was COVID or not. So there was a lot of work around childcare that increased with the onset of COVID-19. Elder care responsibility, similar to childcare, oftentimes that is carried more by women than men I shouldn't say not all relationships are men and women, but more on women. And it increased during the onset of COVID-19 as well. There was increased isolation, especially for the elderly population, and that led to increased need for technology. I personally relate to this because my parents are in their 80s and I've had to set up Zoom for them. I've had to set up, teach them how to use their iPad, messaging and things like that. And it's difficult and it's frustrating and it's something that has to be done on a regular basis. And I love them and I do it for them 100 times. But again, it's additional work that we've had to take on during the COVID-19 pandemic. Usual monitoring of mental health and burnout. Mental health and burnout has always been an issue, even before COVID. But taken together with everything else that I've mentioned already, and also this physical confinement of children and elders and the social isolation, we worried more about the mental health needs, not just of ourselves, some of us frontline workers, some of us just working in the hospital setting, but also, the mental health needs of the people around us. And also in academics, and I think this is extremely important, women and minorities have often been tasked with more service activities. If you look at the Diversity Inclusion Task Force, if you look at the anti-racist committees and all of those things that really developed even more so after the COVID pandemic, especially with the realization of the social injustices. I don't want to say it started with the murder of George Floyd, but certainly that was a catalyst in making people think a lot more about what is going on in our society. That actually increase what was considered to be identity taxation, right? Because we put a lot of that burden onto our underrepresented and minority faculty, especially our Black faculty, especially your Black women faculty. And especially if you had issues around gender, then it was your women faculty that were pulled into these committees. And that increased involvement in diversity initiatives was also an additional burden in the context of our overall academic careers. So many women academics will likely bear a greater burden during the COVID 2019 pandemic, and that's certainly what we've been hearing. In the DOMIC, we actually had a panel discussion back in September because we're hearing all of these issues from our women faculty and the struggles that they were having with e-learning, with childcare, and the additional cost burden associated with that. And I think it's important to look at what happened pre-COVID, because along with the additional burdens of household care and all of those other things that I mentioned, now in the setting of COVID, we have this real possibility of creating even greater gender inequities in academic medicine. And pandemic burnout is rampant and it's real. And this is something that worries many of us in leadership because we worry about recruitment, but we also worry significantly about retention. So remote working, research delays, and childcare obligations are taking their toll on scientists, causing stress and anxiety. This was a poll done by, I believe, the Chronicles of Higher Education and also Fidelity Investments, where they asked over 1,000 physicians, faculty members that focused on the effects of the pandemic, how they felt now versus last year. And 70% of the faculty said that they felt stressed compared to 32% in 2019. More than 2/3 admitted to being fatigued compared to less than a third in 2019. 35% admitted to just being angry compared to 12% in 2019. And what's really worrisome is that more than 50% surveyed seriously considered changing their career or retiring early, which is worrisome as to what our workforce will be like in healthcare and in academics moving forward if we don't do anything now. And this also was disproportionately affecting women in a similar study. 75% of women actually reported feeling stress compared to 59% of men. And in 2019, for women, it was 34%. And about 3/4 of female faculty reported that their work-life balance deteriorated in 2020 compared to less than 2/3 of male respondents. Before I move on to solutions, I also want to make it very clear that gender-neutral solutions maintain gender inequity. A good example of this, I think, is tenure rollback, which I think is a great idea. It allows for just more time, but it doesn't really adequately address the existing gender inequities that have now been exacerbated by the pandemic. So of course, tenure rollback because of COVID-19 is great because it allows people more time to adjust. But unless we really address some of the inequities, you're not really providing the solutions that women need to be successful in advancing their careers. And this is sort of my illustration of you can put a nice bell on each of these, but if you're getting from point A to point B, obviously one of these bikes are going to get there faster. So solutions. I think it's just really important to start with the data. One of the things that we did back in 2014, and I think that every institution should do, is really kind of look, what are the total number of women faculty in each of our departments, in our divisions, and even just look around to see, do we have a good representation of women? What are the proportion of women in each faculty rank? How many are instructors? How many are assistant or associate professors? And how many are full professors? How long have they been in a rank without being promoted? Are more women in one division versus another? And why is that the case? Is it because of ability? Is it because of implicit bias? Or just the tendency that we tend to be more familiar with certain types of people, and that's who we tend to hire. If you don't have women in positions to mentor, promote, sponsor other women, and then everyone else really needs to be educated in their own implicit bias so that they can be allies to be able to promote women until we get to a point where we hire and promote women by resolving some of these gender inequities that we have. We have to understand our own implicit biases. And I think the three areas that are really important when we talk about promotion is networking, mentorship, and sponsorship. So networking, we're all driven towards familiarity. So otherwise, oftentimes we associate with people that we have a lot in common with. And I don't want to be too stereotypical, but if you're interested in golf and you have a colleague who's interested in golf, that's going to lead to a discussion where you maybe talk more about your research. It's just a normal thing that we do, but I think we can be very mindful of that, of who we network with, and are we being really inclusive, and could we potentially be being exclusive because of our implicit biases. I think mentorship is another important area. We tend to lean towards mentorship with those people who are very much like us. Students and trainees certainly look to have mentors that maybe have the same lived experience as they do, which is why it's so important that we create a pool of faculty that represents our student population, so that we have a mentorship pool that continues to overcome these inequities and help people advance in their careers. And sponsorship as well, I think, is extremely important. Who are we likely to promote? Who are we likely to nominate for leadership positions or nominate for a potential grant? When we invite outside speakers, for example, which is part of sponsorship, are we promoting and inviting friends and colleagues that maybe look like us, or are we promoting or are we inviting colleagues that represent that diversity that we're striving for? I can tell you, for full disclosure, one of the things that we had to do in the Department of Medicine was really look back at our grand round speakers over a period of 3 years. And we did identify that we had a lack of representation of women, and we certainly had a lack of representation of URIM faculty. Not URIM faculty to come and just talk about diversity and inclusion, but URIM faculty to come and talk about their expertise and their profession and their successes. And I'm not even talking about the fact that we need to promote women, but we also need to focus on minorities and the LGBTQIA+ community as well. Because again, that networking, mentorship, and sponsorship should exist for all of those individuals to create that inclusive environment. So additional solutions, I think we need to prioritize and develop systems improvements. So initiatives that support women that start to address a lot of those inequities that I talked about. First of all, flexibility in the way that we work. I think that was one of the things that we realized during the pandemic as well. If you're a clinician and if you're a PharmD who has their clinic, oftentimes clinics are structured to be 4 hours in a row. Even with teleclinics, we actually transitioned that into 4 hours in a row. But when you have a parent, whether they're a man or a woman, who now has to deal with e-learning at home, or has a 6-year-old or a 5-year-old, it would be great to have some breaks in between where you can still see the same number of patients, where you can still provide the same number of care, but maybe have 2 hours of clinic and 1 hour break, another 2 hours of clinic, and have some flexibility so that it works better within your lifestyle and what's going on now with COVID-19. I think we want and need institutions to help subsidize some of these responsibilities that we have at home. So partner with businesses to provide dry cleaning services, home delivery of food, house cleaning services, a lot of these things that take a lot of time. When you've actually established all of those and then you have to look for new people to come in, that's a significant amount of time. This isn't just something that applies to women and faculty in the College of Pharmacy or in the College of Medicine. I think this is something that's applicable across the university. Subsidized emergency childcare, especially for essential workers. This was a hot topic for us, especially for my colleagues in pulmonary critical care who had to actually be in the front line, in the ICU, again, dealing with the loss of our nannies, being sick, us having to quarantine as well. And if we would have had a system in place that was institutional, that created places that we could have that emergency childcare that was oftentimes subsidized, that certainly would have made our lives a lot easier. I think we need to think about developing and adjusting promotion standards to recognize COVID-19 research inequities, and I'll talk about the research aspect of that. Clinical care, service, and teaching, meaning that it certainly has been the case that I'm going backward, that women's productivity has significantly decreased. There's no doubt about it. There's multiple papers now that show that during COVID-19 in the early months, there was a significant increase in scholarly activities, but that increase was disproportionately more men versus women. And I think that everything that we just talked about, it can kind of relate to the fact that we really only have a certain amount of hours in a day. And all of these additional responsibilities have been a really stressful situation that have led to more inequities. And women are still productive in their scholarly activities, but they're being outpaced by men in that area as well. And again, we talked a bit about the additional responsibilities, especially in the area of diversity and inclusion, and especially in the area of service that oftentimes fall more on women as well. We want to encourage inclusion of women on research teams. If you haven't thought about, including a specific women faculty member with an expertise, is it because it just doesn't fit, or is it because it just wasn't necessarily considered? Sponsor women for funding opportunities and leadership roles, and then of course provide resources, education, and mentorship with the aim of career advancement. And I want to be very clear that these are not just initiatives for women. These are initiatives that may really push women forward because it addresses a lot of the inequities. But these are all really positive things that can also support our male faculty as well and give them the opportunity to even get further in their careers. So to summarize, I think it's important to understand that we need creative solutions. We need a commitment to diversity and equity in scientific workplaces. We want to make sure that women's contributions are fairly recognized and that they're not penalized for the responsibilities at home, because we need women to come and work and do the job that they were hired to do, and hopefully do it without additional stresses leading to additional burnout, because we want to make sure that we retain women and make sure we give them every opportunity to be successful. So the last couple of slides, I want to talk about what we've been really doing in the Department of Medicine, talk about our framework and our progress, and I put our link to our website there. I'm still very hesitant to say that we've had a lot of successes, because I think we have, but there's just so much more to do and so much more we can achieve in regards to gender equity. I do want to make clear that the idea of creating an inclusive environment doesn't happen overnight, has to be multifaceted, and has to be associated with the strategy. Some of the things that we actually did, I talked about the potential solutions. Even before the COVID-19 pandemic, we actually created a residency leave policy for house staff that was more friendly to families. If you're familiar with medicine, when you're a resident, oftentimes you're only able to take about 6 weeks of leave, parental leave, before you have to extend your training. And what we were able to do is extend that, being creative with some of the rotations to make that a 10 to 12 week leave for residents who choose to have their first child during residency training. Lactation policy has been an ongoing discussion. You'd be surprised where we have a lack of lactation rooms in the hospital and the location of those rooms. Before COVID, there were workarounds. We were able to go to other people's offices, maybe 2 blocks or 2 buildings away. If we could take a break, go eat, would have to walk maybe to, again, a different place to store the breast milk once you're done pumping. But then with COVID-19, all of that went away. Our workarounds didn't work anymore because you couldn't take those additional time and be away from your patients and take that 30-minute walk to a different building. And even if you had 2 or 3 women lactating at the same time, then that availability of those 2 rooms goes away. So this is an ongoing process, but we are trying to be more creative about having lactation packs that you can take, having designated rooms already set in place for women who know they'll be lactating during a clinical rotation, making sure that we have a scheduled time for women so that they don't have to ask to leave. So we're actively trying to create a policy that continues to be friendly for women. Flexible teleclinic we've already done, and emergency childcare I already mentioned. We actually went as far as talking to our hospital HR about creating a subsidized childcare policy. And then we were told that because this was such an important topic that has come up across the university, now currently there is a university effort to try and create this program for everyone. In the interest of time, I just kind of want to go over a timeline of what DOMIC is all about. Again, something that didn't happen overnight. We had our first woman chair of medicine in 2012. Along with that, we created the Diversity Inclusion Task Force to improve the proportion of underrepresented in medicine residents into our residency program. Developed a Women in Medicine Task Force in 2014 to do exactly those steps that we talked about, which is identify women at each of the ranks. Did a needs assessment at that time. We created symposia, lunch series, mentorship opportunities, scholarly activities as well. BRIM, which we mentioned, came to us in 2016 and 17, and with the leadership of Dr. Wada Arife under the DOMIC was able to take that training and now has provided it to hundreds of medical students, residents, and faculty, and it's an ongoing program. You're maybe familiar with our DOM Culturally Sensitive Care series, where we try to address and educate people around certain hardships for accessing care, such as the deaf and hard of hearing, several series on racism, the racial caste system, the impact of COVID-19, not only on women, but the Latinx community. We just completed a 3-part series on LGBTQIA+ care. And then on this bottom right, our ongoing activities, again, is just building upon everything that we've done with the goal of really creating that inclusive environment for everyone, which includes gender equity and giving every woman the ability to succeed in their academic careers. So a couple more slides, as far as where we are now. In 2011, for example, the national average of women faculty in medicine, if you look at the AAMC, which is the American Association of Medical Colleges, was around 35%. And we weren't that far off. If you look at our Department of Medicine, we were right around 37%. In 2020, the AAMC showed that the proportion of women faculty in medicine was about 41%. The Department of Medicine here at UIC is currently at 47%. So we are beating the average, and we are certainly getting very close to having a 50-50 representation of men and women within the Department of Medicine. If you look at full professors by gender in the Department of Medicine, if you look at 2012, women made up only 16%. 8 out of 50 women full professors in the Department of Medicine. And in 2020, we currently have 15 out of 50. So women make up 30% of full professors in the Department of Medicine. And if you compare that to the number that I showed on an earlier slide, again, we're sort of beating the curve nationally. So I know I said some of these things can come off as a bit negative. There's a lot of struggles, there's a lot of barriers, but the one word that really comes to mind when I think about my women faculty, my women trainees and students is resilience, because they've done it. They've come to work, they've taken care of patients and they're succeeding. But I always think we don't have to have our women faculty be as resilient if we can help to overcome some of these unnecessary barriers or adversity. If the system could improve to adjust for these inequities and improve the quality of life of women, we can improve our retention. We can improve our recruitment. If we identify the needs of diverse individuals and give them the tools and the support to succeed, they will eventually contribute to the success of the institution. And that's if we truly believe that diversity promotes innovation. And as my last slide, I want to give a shout out to my pulmonary and critical care fellows, as well as our women attendings, and to celebrate women every day. This has been a really amazing but tough year for us. Our frontline workers taking care of all of our ICU patients during the surge. But I also think it could be easier for our women trainees and faculty to do all the things that they do every day and succeed in an academic environment without the inequity, if everyone was again willing to accept the importance of diversity. So I'll end there.
Right, thank you so much, Dr. Chu. We have one question from one of our viewers. So this question is from Sarah Power. She says that one of the reasons why she decided to enter the field of pharmacy is the ability to offer a work-life balance. Especially for women, this ties to future plans of having children and being there for their families. She has no doubt that it has helped, increase the role of women in the field of pharmacy. Could this similar strategy be used to increase participation of women in other fields?
So if the question is if we make it friendlier for women to raise their families and still succeed in academics, absolutely. I think that's sort of what the whole talk was about, right? Is that we want to make it easier for women to do all of the things that they normally do at home and still have the ability to succeed in academics. In medicine, it's a little bit difficult. One of the things we always say is, physicians never take sick days. We don't cancel our clinics. I think that's also one of the things that we need to work on. We talked about creating a backup system, especially during COVID, because if you do have a child who's sick, emergency childcare is one thing, but could we create a system where we allow women the ability to have those days where they can prioritize family over work and have that support in the workplace as well. So I think creating that environment is this overall idea of creating an inclusive environment, regardless of whether you're a woman, whether you are an underrepresented minority in medicine, or whether you're a minority in general, right? If you create that environment, then you're going to promote job satisfaction, you're going to promote retention and recruitment.
And Dr. Chu, we have one last question from Roxanne Shoa. She says, I apologize if I missed this, but women in academics, do women as assistant professors or associate professor positions pursue other careers, or do they remain in that position for the remainder of their careers?
So let me phrase that. So do women who are assistant and associate professors stay or leave? Is that the question? I think it's definitely both, right? I can say as somebody who actually stayed and now as a full professor, I think that there are women who decide that it's not for them. As many of you know, oftentimes there's a pay differential in academic medicine as well as private practice. But this again, I think goes back to how important is it for us to recruit and retain women? Because if it is important to recruit and retain women, then we don't want to have women make those choices as a black and white, as in we don't, want this academic career because it's not friendly to us, or, I'm being pressured to do things that I don't like to do, or, and then choose a career outside of academic medicine, right? It's not for everyone, I'll throw that out there. But for women who do want to, I think there's a lot we could do to make sure that they get all the tools that they need to succeed and get promoted and advance in academic medicine.
Well, Min, I guess maybe that's it for all the questions. I want to thank you for this great presentation. And I really appreciate you taking time to do this, and everyone who's in the audience who stayed on to listen.
Well, thank you for inviting me.